Thank you all for watching this video. Unfortunately, we did have some technical difficulties when we tried to record the April 6th Retirees Chapter meeting, and so we are re-recording the presentations of both Richard Gottfried and Len Rodberg. We apologize that we were not able to capture the Q&A, but we are very grateful to both Dick and Len for agreeing to repeat their presentations so that they could be recorded. Here now is retired Assembly Member Richard Gottfried, father of the New York Health Act.
Okay, well, hello, fellow public employee retirees. Uh, I always like to begin with a quote from one of my favorite books. Next. So here is Edward Bear coming downstairs now, bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs, but sometimes he feels that there really is another way, if only he could stop bumping for a moment and think of it. Well, there is a better way. Next. Every year, over a third of households in this country that have health coverage, not talking about the uninsured, a third of households with health coverage have someone who goes without needed health care for financial reasons or suffers financial hardship to pay for it. Next. Essentially, everybody is underinsured because of premiums and deductibles and copays that are not based on ability to pay, restricted provider networks and drug formularies, insurance plans that deny, what your doctor recommends. And of course, almost no one has any kind of long-term care coverage, for, home care or nursing home care, unless you spend down to Medicaid or spend tens of thousands of dollars a year on long-term care coverage. And without it, the cost of long-term care, which about half of us are going to need at some point, can wipe out a lifetime of savings, or a family member will give up their career to care for a loved one. Next. And every year in New York State, we waste billions of dollars, tens of billions of dollars on insurance corporation bureaucracy, marketing, profit, executive salaries. Doctors and hospitals waste an enormous amount of money and time on excessive administrative costs to fight with those insurance plans. And we all pay higher prescription drug prices than pretty much any country on the planet because no one health plan has enough bargaining clout to bring down prescription drug prices. Fortunately, there is an alternative. Next. And here in New York, it's the New York Health Act. It's a bill in the legislature that would cover every New York resident with complete benefits, including long-term care, much more comprehensive benefits than any health plan, including real choice, no restricted provider network or restricted drug formulary, no prior authorization for health care, and no premium, no deductibles, no copays, no out-of-network charges. Next. And it's paid for fairly through a progressively graduated tax based on ability to pay, and that tax would apply to earned income, essentially payroll, and the employer would pay at least 80% of the tax on their employees' New York Health Act payroll tax, or more than 80, particularly through collective bargaining. Uh, it would apply to taxable income, other taxable income like dividends, capital gains, etc. The first $25,000 of income would be exempt, uh, zero tax on that income. And if you're on Medicare, the first $50,000 of income would be exempt from the tax, uh, basically recognizing that as a Medicare enrollee, you are bringing an enormous amount of federal money into New York's healthcare economy. And any number of professional consulting firms and academics have demonstrated that almost every New Yorker would be spending less in New York Health Act tax than they now spend on health care and coverage. Next. Now you would ask, how can that possibly be? Well, the key to it is those savings that I talked about. Over $60 billion a year in New York by eliminating insurance corporation bureaucracy, marketing, profit, and executive salaries, by slashing the healthcare provider administrative costs, and by using the bargaining cloud of 20 million covered New Yorkers to bring down prescription drug prices. Next. Now, there would be increased spending by New York Health because it would be picking up our current out-of-pocket costs, deductibles, copays, etc. It would cover the roughly 1 million New Yorkers who are uninsured, and it would pay providers more than Medicare or Medicaid pay, because everybody knows they do not meet the actual cost of care, and the bill requires that they would be paid more than that by New York Health. And so overall savings of 60 billion, increased spending of about 40 billion. You've got net savings of about $20 billion a year in New York under the New York Health Act. Next. Now, we're facing new federal health care cuts. A lot of New Yorkers are going to lose their health coverage. A lot of New Yorkers are going to get kicked off Medicaid. What are we going to do about it? Well, the New York Health Act, in addition to filling all the existing gaps in our system, will fill all of those new gaps as well. And it will pay for it for the filling of those new federal gaps by using a portion of the net savings that the New York Health Act will deliver. And it will cover those losses without costing New Yorkers more, without having to cut other things in that the state spends, and without having to raise existing taxes. And again, that's because of we will be spending the New York Health Act tax money on health care and not on insurance corporations and excessive drug prices. Next. Now, people ask, well, will it be a good plan? In this country, people have gotten used to thinking that if something is a public benefit, it's probably not any good. But the New York Health Act, will cover the governor, the legislator, every state legislator, their families, their staffs, their campaign contributors. So they will all have a powerful interest in making sure that the New York Health Act treats them and their healthcare providers as well as possible, and 20 million of the rest of us get to be part of that same plan. Now, people also ask, well, if it's going to be so good, why not? Why does it have to be universal? Why not make it what they call a public option? Well, the answer is if it isn't universal, if it doesn't get rid of the insurance companies, you don't get all the savings that you get with the New York Health Act. And if it doesn't cover everyone, you don't get the quality guarantees that you get by having all in the same boat. Next. For organized labor, it means health coverage would not be something that has to be bargained for. Uh, Today, every labor leader I've talked to about this topic tells me that uh, every time they're at the bargaining table, they are under pressure to either sacrifice wages and benefits to protect the health plan, uh, or the opposite, sacrifice the health plan in order to protect wages and benefits. By the way, New York City public employee retirees recently had a pretty ugly experience with that phenomenon. And the New York Health Act benefits will be dramatically better than any union health plan comes close to. Next. And, what about Medicare? Well, the bill says that all rights and benefits under Medicare are guaranteed by the New York Health Act. By the way, under federal law, we couldn't tamper with your rights and benefits anyway. And the New York Health Act will fill all the gaps in Medicare. No need for Medigap coverage, or what I like to call Medicare disadvantage coverage. There will be none of the Medicare's extra costs, deductibles, copays, etc. And of course, New York Health coverage for prescription drugs is much more comprehensive than Medicare Part D. Next. Now, some people say, well, gee, why should it be a state plan? Why not make it national? Well, a national plan is just not going to happen anytime soon. I often say it's like wanting a national health plan instead of a state plan is like buying a lottery ticket where the prize is a trip to Bermuda, but you have to go by train. We're not getting there. And New York State and other states, our politics is a lot more progressive than national politics is at almost every turn. There were a couple of years in the 60s and a few years in the 30s where federal policy was much more friendly to labor and consumers. But that's just at no other point has that been true. And there is a long tradition in this country of the states taking the lead on progressive education. New York adopted free public elementary education in the 1780s. We abolished slavery in 1827. Some states did it even earlier than that. New York and other states adopted strong labor laws and civil rights laws long before the federal government. And other states will follow New York. In the late 80s, Minnesota created a child health insurance plan. And in the early 90s, in a bill I sponsored, New York shamelessly plagiarized Minnesota's child health plan and adopted it in New York. I always say I was happy to be in a profession where plagiarism is not frowned on. And then in 97, under Bill Clinton, the federal government passed a law that said any state that does what Minnesota and New York were doing for child health, the federal government would pay about 2/3 of the cost. And within a couple of years, every state in the union has a child health plan like New York's Child Health Plus. Uh, and that's what will happen with the New York Health Act. Next. Now, a lot of people ask, well, aren't we going to need some kind of federal permission or what they call a waiver under, Medicare or Medicaid? Well, fortunately, the answer is no, because both Medicare and Medicaid have always allowed states to do more than they do. For example, New York adopted our senior citizen drug plan a couple of years before Medicare Part D drug plan was created, uh, and it's still better than Part D. New York's Medicaid, from the day it opened its doors in 1970, has covered population groups for which we do not get federal matching money because they don't recognize those groups. Since 1978, Medicaid, by federal law, uh, can't use federal money to cover abortion, but New York uses state dollars under Medicaid to cover abortion. And that is essentially what will happen with the New York Health Act. We don't need any kind of federal permission. Next. So, how would it work? Uh, if the federal government just says, the heck with you, New York, do whatever you want, we're not going to help, uh, then the New York Health Act would wrap around uh, federal benefits like we do now. I'm a state employee retiree. When I go to the doctor, Medicare pays a portion of the cost, but my state retiree benefits uh, pay a big chunk on top of that. I pay a small copay. Now, we didn't need permission from Washington to do that. I'm not sure Washington is even aware that we do it, but we do it. And the New York Health Act will similarly wrap around uh, Medicare and Medicaid benefits. Now, the ideal way for it to work would be to actually merge Medicare and Medicaid into the New York Health Act. The federal government would send us a check every month for what they would have spent in New York for Medicare and Medicaid benefits. It'll all go into the New York Health Trust Fund and all be administered as a single payer plan. Now, that would be a little more efficient, be easier, but the plan will work perfectly well, even without that kind of combining of the programs. Next. So here's how to contact me if you want more information. And then we've got a couple of uh, websites where you can get more information. And if you really want to get into the weeds and read the bill language yourself, if you go to this website called Public Ledge Info, you can read the bill. You can download a copy of it. It goes on at some length, but you're free to do it. So that's the story. Uh, we can leave this slide up if you want to jot down the information. Now, I also want to talk about um, particularly about public employee retirees and how this affects them, because you're all public employee retirees like me. Um, Now, when I say public employee retirees, everything I say will include, and it's spelled out in the bill, will include your retiree benefit beneficiaries. Uh, and again, your benefits under the New York Health Act will be on top uh, of your Medicare benefits. Uh, if you are a New York resident, uh, you will be fully covered by New York Health Act benefits uh, instead of your current very limited retiree benefits. Uh, and remember, that includes, under the New York Health Act, long-term home care and nursing home care without having to spend down uh, to the poverty level to get Medicaid coverage or spending tens of thousands a year on long-term care coverage. Uh, and this includes uh, New York Health paying the bill if you are temporarily out of state. For example, if you're traveling, if you break your ankle hiking in the Grand Canyon, or if you're spending a little time in a winter home in Florida, the New York Health Act will pay the bill out of state. Uh, and, a lot of people live near the state border. They may live in Dutchess County, close to Connecticut, where a lot of people have a family doctor uh, who is in Connecticut. Well, the New York Health Act will pay if they go across the border to Connecticut or to Pennsylvania to get care. Um, Now, if you are no longer a New York resident, a New York State resident, bear in mind that today your retiree health benefits are vulnerable. They are not protected by law. The New York City municipal retirees uh, came close to disaster on their health benefits because they are really not guaranteed by law. But under the New York Health Act, there would be a guarantee that the benefits, the out-of-state retiree health benefits, whatever you have as of when the New York Health Act gets enacted, will be guaranteed for the future without change, without reducing the benefits, uh, without reducing the public system's financial contribution to that benefit, and without increasing the retirees' burden for those benefits. So if a retiree does move out of state, they will be a lot better off than they are today.
Okay. Hello there, everyone. This is just a description of the various things I do and have been, from a teacher at Queens College to an activist in helping to create Physicians for a National Health Program in 1989 and the Campaign for New York Health in 2015. And I've been working with PSC Social Safety Net for probably 10 years. So let me start. I want to provide a little bit of overview on why we need the New York Health Act and why the United States is such an outlier. I then want to provide you with a graphical presentation of some of the information that Dick Godfrey provided you. And then I have some additional comments to make about how we move forward from where we are today. So this is, I always describe this as my favorite slide among those that I use. This shows for over a period of, I think, 25 years, healthcare spending for various countries as a percentage of their gross domestic product. And that red line at the top is the United States. Everyone else is between a half and 2/3 of what we spend. And the major difference, besides the cost, is that they cover everyone. And we, as you know, do not. And what we do cover is spotty and difficult to use and not always accessible to people. So clearly we could do better. Other countries have figured it out how to do it, mostly by involving government in seeing either that the healthcare is provided directly, as the British do, or as overseeing the financing of it and perhaps funding it themselves as a government, which is what Canada to our north and Mexico to our south do, for instance. This shows, basically gives you insight into why we're such an outlier. The orange line there is the spending per person on healthcare by private insurance. And it escalates over time because the private insurers can't control costs and the providers can charge what the insurers are willing to pay. And they just pass the costs on to the people who pay the premiums. which is all those of us who are on private insurance. The lower lines, the blue and the green lines, are public insurance, Medicare and Medicaid. They control costs. They set the rates, and the providers take those rates because so many people are covered by them. What I always say is they cover the sickest part of the population too, the elderly population and the poor. But they can control costs because they are government and have wide access. So some way or other, we need to involve government in either providing the care or paying for it. So here's how the financing under the New York Health Act would work. Dick gave you a summary. I'm showing you the same information under graphically. He and I worked together on this economic analysis, which was done first by Professor Gerald Friedman of UMass Amherst. And then I did a follow-up study in 2018, taking off on a study that the Rand Corporation did for New York. And then I've updated it since then. So the red bars going down show the three sources of savings under a publicly financed healthcare system. People sometimes call it single payer, sometimes call it, if it's national, call it Medicare for all. It's basically government funding of the healthcare system, which remains mostly private, but also some, of course, public, like the public hospital system. So there are three, as I say, three sources of savings. First is private insurance has an overhead that averages about 15%. It's the expense of processing claims, but also executive salaries, profit, and various steps they take to try to reduce costs by controlling access. The overhead for public insurance is, for Medicare, is less than 2%, and for Medicaid it's about 6%. And the difference is Medicaid has to, and Medicaid providers or Medicaid administrators like New York State have to spend money verifying qualifications that the people who are access to it, who have access to it, are actually qualified to receive it, because you have to be below a certain income level. The second source of savings is by the providers, who have a simpler system to deal with than the complicated system where they have dozens of insurance plans to deal with. And we've done the estimate, and other people have done similar estimates of what the savings would be through that simplification. And third is being able to negotiate drug costs with the drug companies for 20 million people in New York State. Medicaid already in New York State does that and achieves significant savings. We'd get additional because there'd be the whole population of the state rather than about a third, which is covered by Medicaid today. So total savings of $60 billion a year out of the total of about 350 billion that's spent on healthcare each year in total. I'll show you that in a few minutes. Well, there are additional costs, after all, because we're going from a partial system to a complete coverage system. So first is it costs more to cover everybody instead of 90% or so as are covered today. But you're going to cover them better by eliminating cost sharing, eliminating the money that has to be spent in copays and deductibles in order to actually see a doctor or go to a hospital. That is the spending at the point of service. That's eliminated under the New York Health Act. Second is improving provider fees. Medicaid, as we know, underpays providers. Excuse me. And Medicare, too, doesn't pay as much as as private insurance is today. So we I mean, in doing these estimates, have assumed that we equalize payment up towards the private insurance level. And finally, is extending long-term care to everyone. Today, only people who are on Medicaid have access to long-term services, which is part healthcare and part maintenance of quality of life services. And we and others have estimated it, and it's shown in the blue bar. The result is a net savings of about 5% of what we spend today, which is real money. It's $17 billion a year. This was estimated for about 2 or 3 years ago. Now, here's an overall picture of how healthcare is paid for in New York State. The pie on the left shows the total, the federal government through Medicare, Medicaid, the Affordable Care Act or Obamacare, and other community health center subsidies provides about a third of the funding. The state government provides a portion. County governments in New York State pay for a portion of Medicaid. And then there are other charity funds and so on. The light green shows private insurance paid for by employers mostly, but also individuals who aren't employed or they don't get insurance through their employers, but they buy private insurance. And then the copays, the 11% that's out-of-pocket costs by those of us who still have to pay the part of the cost. Under the New York Health Act, the green portion would all be replaced by a new public health tax, the New York health tax, which would cover 41% of the total cost, with the savings of, say, 4 or 5%. So that's the overall picture. So how would the taxes be allocated by income? Here's an example. As Gottfried described, it's a combination of a payroll tax and a non-payroll tax. This is a model. The numbers are not in the legislation. It just describes the structure. This is an estimate of one model of how to do it, and it shows that there will be no tax below $25,000, and then it would rise slowly to a maximum of 10% under my current estimates I've made of income in New York State. So this is the current plan. And this, I say this was worked out jointly with Assemblyman Gottfried, who's actually really a pleasure to work with. Smart and dedicated. He's been following this and promoting it for more than 30 years. And he knows what he's talking about, but he and I don't agree on everything. And I want to give you several points on which I don't agree. The Delegate Assembly's resolutions on the New York Health Act describe it as a work in progress, meaning that it needs improvement, and labor unions should be part of seeing that it's improved. I work with a group, I co-lead that with Martha Livingston of Physicians for a National Health Program called Labor Activists for New York Health. We're trying to build support for the New York Health Act among the labor movement. And we did a study about 3 years ago on how to modify the bill to be more attractive to labor. And what I want to show you is two of the principal points that we made there. The first is that the payroll tax is not necessarily the best way to pay for healthcare. In fact, in New York State, most of the money in this model comes from, 2/3 of the money comes from the non-payroll tax. And how it varies by income isn't specified in the bill, or what its level of tax would be. but it is the dominant source of revenue. Unions generally oppose payroll taxes because they suppress employment. Every new employee means more taxes paid by the employer. As I said, large amounts of the income that are generated by this tax plan that's in the bill are from the non-payroll portion, but the income structure today is much more complicated than this tax reflects, and it's not how the state collects its taxes by and large. And lastly, there's a technical problem, which is the New York Health Act covers people who work in New York State but live elsewhere, mainly to simplify the tax system and simplify the life of employers. But since it's a payroll tax, the tax is only on the worker, and there's no provision in the legislation right now to cover the workers' families. So that's a real serious defect. So there are alternatives to consider. The Peter Arno of P&HP and the folks, economists at UMass Amherst, have developed some alternative proposals, which are quite complicated, including a variety of taxes, including a gross receipts tax on businesses, and a very small payroll tax. The suggestion that we've made here is to take the current state payroll household income tax, which is shown in the graph in the blue lines by income. It's a progressive tax, which has existed for years and is, it's now being debated to tax the rich to raise the portion paid by the upper income people. If you add a surcharge to the existing state household income tax, as remember, I'm talking about taxing households, not individuals. If you add a surcharge, which is twice the current income tax, you will pay for the healthcare system in full. So it's a simple tax. People are familiar with it. They're already paying it. It would be higher, of course, because you're paying for healthcare. There wouldn't be any more healthcare premiums, insurance premiums. This would cover it. But it's an alternative that should be looked at. The second point I want to make is we should change the way the current plan provides for getting the system actually moving. Here's how it currently works. The bill in its current form, the idea is pass the bill. So suppose hypothetically it were to pass next year. The administration would then spend a year developing the reimbursement system, but it would also develop a proposal for the taxes that would pay for the plan. And then that would go back to the legislature, and the legislature would review the administration's plan and presumably pass a revenue plan. So what's wrong with this? Well, there's two very serious things wrong with it. First of all, when you go out and talk to people about the New York Health Act, everybody wants to know what it's going to cost them, whether they're individuals or employers. And we can't tell them. I can show you the model that I just showed you, but it's only a model. It's not what necessarily the administration would propose in using the plan of illustrated here. So I'm saying that the cost should actually be built into the bill. Medicare did that in 1965. They put the taxes in. 11 months later, the Medicare program started. 20 years later, they had to make a modification of it, and they did. in 83, and it's been the taxes for the last 40 years. The tax structure hasn't changed. It's a percent of income, and income goes up, and the percentage of income goes up with, and the taxes that uh, you get from a percentage tax goes up with it. Um, the second defect in the current plan is the impossibility of actually doing it politically. Um, I mean, we've been advocating for the New York Health Act for 30 years. I've been advocating for single payer for 50. Um, it's very difficult to organize for healthcare. It's an abstract, complicated subject. To build the mass support for it, to get it passed, it'd be a monumental political achievement. To be able to do that twice seems to me impossible. That is to get people to, we can get 200 people these days, advocates, to come to Albany to lobby, to get really large numbers of people coming to Albany or beating on Albany's doors to pass this bill. And then a year later, to support a tax plan for it, that seems to be out of the question politically. That we should pass it in one step by putting the dollar figures into the bill and argue about it and pass it. That's my view anyway. Um, Finally, I want to say something about organizing. Most of the organizing today is focused on the legislature, on persuading legislators to support the bill, and we've been very successful. We have majority uh, support, majority sponsorship of the bill in both houses of the legislature. As professionals will tell you, that doesn't mean if it were brought to a vote, it would pass. Sponsorship doesn't mean that unless they vote for it, because they haven't really heard from the opposition. They've heard from the advocates. They haven't heard from the opposition. We need to build public support, particularly from the power sources in this society, which are labor, business, and the hospitals. The hospitals are major financial institutions, $1 billion institutions, and they have very great political influence in Albany. Our job as a union, it seems to me, is to build support among other unions. And we should be building a coalition. I would look forward to a Labor for New York Health or coalition being built, starting with us and with other supporting unions, and move out in there. So I favor outreach rather than what I refer to as in-reach, which is going to the legislature. It's easy to go to the legislature. It's harder to go to the public, but that's the way we should go. So thank you. These are the comments I wanted to make, and I'm happy to be able to make them here.
Hi, how are you?
Okay, this is Jen Gabori, who is our first vice president of the PSC. She also chairs the Hunter chapter, and she's going to talk to us about the PSC, the PSC's position, what some of the issues are for us as an organization. So, Jen, it's all yours.
Great. Thank you so much, Anne. Thank you all. Thank you, here, folks in the retiree committee. I know a lot of you, many of you, but if I haven't met you formally, right, I'm Jen Gabori. I am, just as Anne said, from Hunter College. I'm a political scientist by training. I teach in a gender studies department, and it's really nice to be here with you all. Many folks in this room have spent years and years advocating for single payer healthcare. About 30 years ago, I stood in a parking lot in a Safeway, California, for about 4 months trying to get signatures to put single payer healthcare on proposition in the state of California. And it's both frustrating and exciting to be here talking about it in this forum. It is a real honor not only to speak after Professor Rodberg, but of course, Emily, Godfrey, about this work. I see my goal here or my role here talking as a PSC officer, essentially about organizing for the New York Health Act. So the PSC supports single payer healthcare and supports the New York Health Act as a work in progress. We believe that there may be some adjustments that need to be done in the legislation, but are committed to this and have committed to the campaign for the New York Health Act. Just a little bit ago, this morning, I was on the phone with Melanie Durango from the Campaign for the New York Health Act, and we were talking about some things that the campaign are going to be rolling out in early May. And it underscored the urgency of doing some New York Health Act organizing within the PSC in the month of April. So just before I got on this meeting, I went ahead and looked. April is a very crowded month for us. In addition to all of the organizing that we are trying to do to turn out a significant percentage of our union for May Day. I am going to tentatively look at the evenings of April 14th, the 27th, and the 28th of April to do a Zoom meeting, to have Melanie come, other folks here who are interested in New York Health Act organizing, and we'll be polling people. But I really want to be able to pull people together who are interested in New York Health and organizing work. And obviously, this is things that have been these are conversations that I know many of you are engaged in here. In this chapter, also in the social safety net group, but I think it's time that the PSC just go ahead and organize that meeting to be able to support and recruit, especially more active members, right, into this fight. Many of whom are already, already working outside the PSC in that capacity. So I see that organizing work and moving that forward is the central thing that we can do as the union. We know with DC 37 going into contract negotiations this summer, right? They will be first up in the new administration, and that it will be important how we frame this debate and how we talk to our siblings in New York City labor in terms of talking about all the things, right, that we've just gone over about the savings and the ways in which it will make money available, right, to workers and increase the pie if we are able to make progress. If we are able to make progress on this issue. And so it feels really urgent in terms of a new cycle of bargaining starting under the new mayor. It also feels like there's a lot of opportunities there. So I am really excited that we have the chance to do this work and move it forward, even as it's, of course, a moment of terrible terror, right? I remember going to an event where Melanie was speaking a couple months ago, and she was saying it feels really terrible that next year people are going to die when they are thrown off the essential plan, and then people are going to then pay attention to this issue, and that feels awful, right? And so we're at a critical moment right now. I'm spending most of my day almost every day of the week, I'm spending time on the revenue campaign, right, to make sure that we are asking the ultra wealthy to pay their fair share. And it seems to me that dovetails exactly with the work that we need to do on the New York Health Act. And in fact, one of the things I will be following up with to confirm with you all is that there's very likely to be an event at the end of this week. We're just trying to confirm with NISNA on the day and also confirm with Gustavo Rivera's schedule, but at a hospital in the Bronx, calling attention to the need for both the New York Health Act, a bill that Assembly about that Senator Rivera is sponsoring in terms of like trying to protect people on the essential plan and ultimately to tax the wealthy in order to like move out of this moment. But as we all know, it is a single payer health plan that is the permanent answer, right, to this. It is the permanent answer. And also in a moment when the New York State budget is like underwater, the slides that we have all seen in this meeting today provide the answer. So I want to make sure that we focus on getting organized, and that's the thing I want to, that I want to do. And I'm happy to talk more about how we in the PSC can most effectively work together to do this work. Thank you guys so much for inviting me to be here with you. It's always a real pleasure.
Okay, Jen, thank you very much. I guess we should go to questions. And I don't know what happened to Len, but we'll try to get his slides and put them up on our website. I think that would work. Before I call on people, one question that has been coming up quite often. And I guess, Dick, maybe that's a question for you. Is Dick still here? I don't see him. All right. Well, the question
Yes,
is
I'm still
what?
here.
Oh, yes. What about people who live out of New York State?
Well, the bill covers, like most state programs, it covers residents of New York. If you're no longer a resident of New York, unless you work full time in New York, uh, you're not covered by the bill, by New York Health Act. If you've got public employment retiree coverage that would follow you out of state, then the bill adds would add language to the state law saying that that health coverage cannot be taken away from you. We can't make you pay more for it. And again, as New York City municipal retirees have found out, you don't have any guarantee like that today. But if you continue to be a New York resident and you spend, a few months in Florida, or if you live, uh, you know, just on the New York side of the Pennsylvania border and your family doctor is in Pennsylvania, as is true for a lot of people, New York will cover that out of state care. If you're vacationing in the Grand Canyon and you break your ankle, New York will pay the Colorado emergency room to repair your broken ankle. So to be covered by the New York Health Act, you need to be a New York resident. If you've got public employee retiree benefits that would follow you out of state, the bill guarantees that those benefits and the public employer contribution, financial contribution to those benefits will continue.
Thank you. Audrey Cohen?
I think you just answered the question I posed, but let me just make sure. So I'm a New York City retiree. I spend some months in California, and I'm thinking of possibly moving to California. So if I move to California, I think you're saying that then I would have my Medicare insurance as I currently do, and I would drop the New York Healthcare Act, even if I've contributed to the New York Healthcare Act. Do I have to drop Medicare while I'm still a New York City resident if the New York Health Act goes into effect? In other words, at what stage do I
Okay,
lose Medicare and what stage do I pick it up again?
under the New York Health Act, as long as you're alive, you will keep Medicare. As I said, the bill guarantees that nobody will lose any right or benefit under the Medicare law. The federal government wouldn't let us tamper with your Medicare benefits, but the bill says that the law will not do that anyway. So if you stay in New York, you get your Medicare benefits. If you move out of New York, you get your Medicare benefits. If you move out of New York and your child was going to public school in New York City, your child will no longer be able to go to New York City public schools if your child moves with you
Of
to New
course.
Jersey, right?
Of course.
Oh, well, right. And so if you're no longer a New Yorker, the New York Health Act benefits will not follow you to California. If your current public employee retiree health benefit would follow you to California, the bill guarantees that that will continue and that your employer's contribution to that benefit cannot be reduced and your burden cannot be increased.
But while I'm a New York City resident, am I going to be covered by Medicare or by the New York Health Act? I'm not sure which is going to cover me.
While you are a New York resident, you will be covered by Medicare. The New York Health Act will not touch anybody's Medicare rights or benefits. The federal government wouldn't let us do that if we wanted to, but we don't want to, and the bill says so in black and white.
So then why should I sponsor this bill? In other words, if I want to
Because
get long-term care insurance through New York,
because under Medicare, think of the Medicare drug benefit. It is nowhere near as complete as the New York Health Act benefit. If you go to the doctor or the hospital, Medicare pays part of the bill, but not the whole bill. That's why people have Medigap coverage. Under the New York Health Act, nobody would need Medigap coverage because the New York Health Act will fill those gaps.
in other words, I would be covered by both insurances while I'm New
Yes,
York. That's what I
yes,
didn't understand.
absolutely.
Thank you.
Yep.
Great.
Just
Uh,
just like today, I am covered by Medicare Parts A and B and by my state retiree health benefit, except the New York Health Act will be even better than my state retiree health benefit.
Thank you.
Yep.
Lorraine Cohen?
I want to thank all three speakers. And Len mentioned in his first slide that he is a member of the PSC Social Safety Net Working Group. That working group has been many of our members, especially people like Len and Eileen and Jim Pearlstein, have been working on trying to get a single payer system for years. They are very familiar with the groups out there, and we are very, very happy that the PSC leadership is taking this on in a very serious way, and actually has some hope that something like this can be passed, because as you probably know, for many people, this seems like a pipe dream, that can never happen. But that's true of many other important pieces of legislation and reform that we thought would never be passed, and eventually, with struggle, with organizing, it was passed. So I want to invite you to join the Social Safety Net Working Group. We're actually meeting tomorrow. We meet monthly, and we are going to be discussing a campaign that will also mesh with the PSC leadership's campaign, and to say what do we need to do to raise awareness among faculty, among students, PSC members. What is it going to take to raise consciousness and have people mobilize on behalf of this legislation? I'll put my email in the chat. Thank you.
Thank you, Lorraine. Bill Ferns? Okay, why don't we go to Erwin and then we'll come back to Bill Ferns. Erwin?
Okay, my question is for Richard Gottfried and for Jen, and it has to do with the support for the bill from the labor movement, which I believe was there at the inception of this bill. It's been here for many years, but many unions, including many of the big public unions, no longer support the bill. And Richard Gottfried has made a very good case why unions should support the bill, because it would improve their bargaining position with their employers. So you would think that the union movement would be behind such a bill for its own interests as well as for the larger general interest. So my question goes to both Jen and Richard Gottfried as to why that is not the case.
Well, among private sector unions, the support for the New York Health Act is strong and growing. The UAW in New York, a lot of the communication workers, RWDSU, New York State Nurses Association, 1199, I know I'm leaving some out, uh, uh, strongly support the bill. Uh, the real gap in labor support for the bill, I'm sorry to say, is with almost all the public employee unions. Uh, Obviously, PSC is an exception. Uh, the New York State Nurses Association likes to point out that their single largest bargaining unit is the New York City Health and Hospitals Corporation. Uh, so they like to say that, well, in a way, they're a public employee union. But DC 37, NYSUT, the UFT, et cetera, CSEA, I don't know what's in the minds of their leaders, whether they somehow see some advantage in terms of union politics, being the one who delivers health coverage to their members. I don't know. Over the years, they've raised a couple of concerns about the bill. Like they said, oh, how do we know the benefits will be as good as our union benefits? So we put language in the bill that says that if any state or local government anywhere in the state of New York, the smallest little school district in the Adirondacks, covers something that isn't already covered by the language of the New York Health Act, the New York Health Act will cover it for all 20 million New Yorkers. And the city municipal unions said, well, you say that the employer should pay at least 80% of the payroll tax. We've negotiated the city up to 100. So why should we have to negotiate it back up to 100 again? So we put language in the bill that says whatever percentage of the premium a public employer is now paying, they must pay at least that percentage of the New York Health Act payroll tax for their members. Um, so the specific concerns that they've raised, oh, they also said, you know, we don't think we have enough seats on the New York Health Act board. So, I've said to them, make us an offer. It's negotiable. And we haven't heard from them. Uh, Hopefully, there's beginning to be more and more rank and file support for the bill in the public employee unions. Uh, I know the bill sponsors in Albany keep reaching out to them saying, let's talk about what your concerns are. So that may change.
Okay, Jen, did you want to comment?
Yeah, I would say a couple things, and they overlap perfectly with what the assembly member just said. I mean, I think that a lot of us in this room have been to NICET meetings where single payer healthcare has been discussed on the floor with thousands of delegates there, and you have heard just as has been suggested, people stand up and say not only do they like to be the ones to deliver the healthcare, but in their union they do not believe that people will join. There's no point in people joining the union in some contexts unless they do receive their health insurance through their union, and that's one of the reasons they participate. Um, the BSC, of course, does not believe that and strongly urges otherwise, including all the things that are on the table, including the additional money that would be available to us to bargain and enlarge the pie in lots of other ways. I do think that we have a lot of work to do to educate people about the improvements in the bill that Dick was just talking about the kind of parity and the way the bill has been amended to make it friendly for municipal labor to come in. When I have shared some of those things with people in other unions, they've said they don't think that's true. And I've sent them the language and then don't hear back from them. Um, and there is real resistance, right? And there is real resistance that I think is right. I think a lot of us know that is tied to being the agent that delivers the healthcare for lots of, I think, highly irrational reasons or reasons that have to do with power and really cynical other reasons about bargaining and how bargaining works. And so I don't love that. I don't like that that's true of many of our union siblings, but I think, right, unfortunately, it is the case. Something I would tell you that you all here in the retiree committee may not be as have the benefit of not following as closely. We are having some real struggles with the new health plan that was enacted by the MLC, principally by folks in leadership at U of T and DC 37. And there's probably an aspect of this bill that is you may be aware of that Michael Mulger has just communicated to his membership, and that it's that Presbyterian may be leaving our system. And honestly, I'm so glad we abstained in the MLC, the PSC, precisely because we said we had deep concerns about this health plan. I hate to capitalize on the woes of what our members are going through right now, but this is a very good moment with the sort of like federal meltdown and the real struggles that we are having with our current health plan to say there is another path here and that it's terrible that the path forward may come out of crisis. That's in fact the case. Presbyterian is holding out because they want more money. Nothing in our health plan, as everyone has just said, right? Nothing in our health plan does anything to capitalize upon the savings and the price controls that the city should be using. It's so embarrassingly bad, right, that we don't use our purchasing power. So this is a good moment for this advocacy work and for terrible reasons.
Okay. Bill Ferns?
Yes, okay. Sorry about before.
Okay.
Besides being a CUNY retiree, I also work with a group called the Senior Advocacy Leadership Team in the Lower East Side. And we've actually done several presentations with Richard. And we've managed to get a Community Board 3 in Manhattan to pass a resolution supporting the New York Healthcare Act. And Richard and I have been working on Community Board 1, which is downtown. One point, besides all the other points they brought up, and Melanie DeRigo of the Campaign for New York Health had raised it to me a couple of meetings ago, is that this will should have a positive impact on real estate taxes throughout the state. If you consider how much of the budget of various municipalities and counties are related to supplying healthcare to their people, and how much time they have to spend shopping around, and every year they come up with a new plan, et cetera, and they don't have buying power because sometimes these municipalities are small. This will relieve them of all that cost. So while they will have to pay the payroll tax, it'll be much, or whatever plan they come up with in terms of that, it will alleviate a major part of the cost of municipalities, because if you figure labor is probably the single biggest cost between police, fire, roadworks, education departments, et cetera, and then of the pay to the public employees after wages, medical care is probably the single biggest. So if you remove much of that cost, it will make it possible for them to lower property taxes, which will be a selling point to various more conservative legislators who may not want to support the bill unless they hear about this. So that's another issue to consider in support of the bill. Thank you.
Thank you. Francine?
Is there a difference between single payer and New York Health Act?
Well, single payer would mean that the New York Health Program would be making one payment to your doctor or your hospital, and that would cover or that would include in it whatever Medicare or Medicaid would also pay. Now that requires the federal government to say, yes, we'll go along with that, which would make a lot of sense. But if the federal government doesn't go along with that, then like my retiree health benefit today, Medicare would pay part of my doctor bill, and my state and the New York Health Act would pay the other part of my bill. Now, when I go to the doctor, neither of those payments involves any effort on my part. It doesn't even really involve any effort on the part of my doctor. My doctor's computer sends part of the bill to Medicare and sends part of the bill to United Healthcare for my state employee retiree share. So if New York Health operates that way, as a wraparound to Medicare and Medicaid. Uh, it'll still be, paying for everything. You'll still be able to go to any doctor or hospital. There will still be no out-of-pocket charges, et cetera, et cetera. It's just technically there will be two payments. Um, but again, if the federal government is cooperative, there would be one payment.
Got it. So there
So,
is a slight difference because you had sort of made that insinuation in your talk, but I wanted to make sure I understood correctly. Got it.
yeah, the difference is really purely technical. And, you know, my doctor's computer uh, will know the difference, but me and my doctor, it will not enter
Right,
our consciousness at all.
right. And in terms of the public employee unions not supporting the New York Health Act, probably has to do with membership because of the new legislation that not everybody has to um, pay, that it doesn't come straight out of people's paychecks anymore. The unions are having problem with membership, and probably the
Well,
idea of the union not providing medical benefits will affect membership again. So it's, to
on the
me,
other
there's a
hand,
membership issue there.
today, if you work for a public employer and you choose not to pay your union dues, you don't lose your health benefits, right?
Right.
No.
So the fact that the union bargains for the health benefits, and maybe the union welfare fund may even help to administer the health benefit, doesn't mean that you have to be a member of the union in order to get that benefit.
That's true.
And if the union is saving money by not having to pay for the health benefit, uh, they will be able to focus more of their effort on wages and retirement benefits and other benefits, and focus effort on making sure that instead of paying 80% of the New York Health Act payroll tax, they can bargain to get it up to, 95 or 100%.
Yeah. Thank you.
Okay, thank you. Marcia?
By the way, in case you're wondering, this is my granddaughter in the background.
Yes,
Lucky. Okay, can you hear me?
yes.
Okay, first of all, Mr. Gottfried, I want to thank you. You have been an example to me of somebody who doesn't give up. I mean, and I
Well, thank
totally
you.
appreciate it. I mean, really, it's unbelievable the barriers that have been put in the way of this. Unbelievable. And so you don't bend, you get it, you stay strong. Okay. I wanted to know, I am not covered by I'm a retiree of the CUNY system, and the PSC, but they don't cover my health insurance in retirement because I was an adjunct. So would I be encompassed by the New York Health Act? Would I fall into that?
Absolutely.
Okay.
Assuming you're a New York resident, the New York Health Act uh, would cover everything
Okay,
that,
and so
that
what is
Medicare
the
does not cover
objection?
for you.
I understand the objection of the big unions. They think they'll lose their membership. So in some ways we have to wean their membership from them. We have to say to their membership, it's so what that they're your union. They can do more. Join this and help them get better. Right? In other words, you're not going to lose them and they're not going to lose you. You just have to understand how to manipulate, have the New York Health Act and have your union. I mean, that's
Yeah,
what has to be done. And people have to be that's the education part, right?
Yep.
So we will pursue it.
Thank you.
Thanks, Marcia. Jim Pearlstein?
I want to join with others in thanking Richard and Len and Jen for this presentation today. All the difficulties understood. I have a comment and a question. I guess the question is mainly for Jen. We've got an activist colleague in UUP who says the New York Health Act is the greatest piece of legislation that nobody's ever heard of. And it's true. And those of us, certainly in the social safety net working group, who've been working on this healthcare issue for quite some time, understand we've got a massive public education campaign that we have to undertake. That we've been trying, not so successfully, to engage in for a number of years, but it's got to be much bigger and much more profound. And it's, starting within our own union, despite the relatively elevated consciousness in the PSC. But it's also a leadership problem, as people have recognized. The union opposition is, and it's primarily leadership opposition. It's not opposition of the uninformed rank and file. Leadership opposition has to be confronted. And it seems to me that the PSC has now put itself in a position where it could play a critical leadership role in this campaign. The PSC is now publicly supporting this piece of legislation as a work in progress, but supporting the legislation. And there can be a coalition of the willing, the leadership of the PSC, the leadership of the Committee of Interns and Residents, NISNA, UAW 9A. And if that coalition of the willing within leadership begins to play a role in the MLC and in the New York City Central Labor Council, that can have a profound effect on municipal unions and their leadership in general. And I think it's, so the charge is a charge to us as rank and filers to do the public education and the rank and file education. The charge is also to leadership to work with leadership on this issue. Thank you.
The only thing I'd say is I agree. And it's a conversation that I've also had with colleagues in NISNA, Doctors Council, CAR, 9A, CWA. Yes, I agree with you.
Okay. Bob Cermelli?
Yes. Is there a substantial opposition below the radar from major insurance companies?
Well, sure. During the many years when we had a Republican majority in the state Senate, the bill would pass overwhelmingly in the Assembly with a Democratic majority, but go nowhere in the state Senate. And in those days, it was because of the opposition of the insurance industry and big employers. Once we got a Democratic majority in the state Senate, the opposition from the insurance industry and big business all of a sudden didn't really matter much politically. But that's when the public employee unions, by and large, woke up and said, oh, this isn't just a silly bill that they pass in the Assembly. This could really happen. And they all came out with their opposition. And ever since 2018, it has not come to the floor in either house. So, yeah, the insurance industry opposes the bill. At this point, that is not what's holding up the bill.
Are there any other questions or comments? Well, I think we want to thank Dick for all of his work, as Marcia said. Uh, I agree. And even in retirement, uh, still pushing this, which is very admirable. And thank you for,
There's one
oh,
more question.
I'm sorry.
No, that's
I'll
okay.
thank you again. Julie Agus.
Yeah, just a quick comment that I think as we've seen in work in the union in immigrant solidarity, coalitional work across many organizations, as well as within the PSC, that there's a moral element to this, to the argument for the New York Health Act as well. I mentioned in the chat Healthcare Conspiracy, the wonderful short that a playwriting graduate student in the program that I was in for 30 years made, Richard Holman. And I think that that's a piece of the argument that film makes, even as as Richard has done here today. It really clarifies the history of the bill, the beginning of the revisions to the bill, which is really useful because it makes it clear to all of us in ways that all the questions that are arising show we need. But I do think part of the union's campaign should address the moral idea that the New York Health Act, piggybacking on the earlier bill in Minnesota, could be a model for the nation. I've heard people argue we shouldn't approach it at the state level because we really have to approach it at the national level and all of that. That's been addressed by Richard today. But I think we can turn that argument around in terms of creating models that will support all Americans and equity and across generations and support labor at the same time, support Americans throughout their working lives so we don't have to worry about the catastrophes that may befall in retirement. Anyway, I'll stop there, but I'm just saying that I think that moral piece could be very effective within the campaigns that emerge in support of the act.
Thank you, Julie.
You
Are there
before we go,
Yes.
I just want to say something quick about Len Rodberg.
Yes.
At the beginning, someone referred to him as having been a consultant in the development of the New York Health Act. And two things. Number one, Len's role in developing the bill and the economic analysis to support it and campaigning for it is way beyond the word consultant. And number two, if you think from the word consultant that suggests that somehow he got paid, not a nickel.
Yeah.
He's a real hero in this effort.
And I really feel bad that his sound was so problematic. I don't
I
know.
think we will ask Len if we can put his PowerPoint slide up where people can access it and maybe with a commentary along with it.
Right,
We'll work with him to see if we can get his presentation to you somehow.
right, right. So thank you, Dick, for all of your work and for coming today to talk to us. And ditto to Jen. Thank you very much for making time in your busy schedule to talk with us and for your work on this issue with the social safety net. So I guess we should move the agenda, and maybe Bonnie and Diane could stay on at the end of the meeting for a few minutes and we can figure out how we want to uh, make Len's work available. So thank you again, Richard Gottfried and Jen Gabori. Great presentations.
Thank you for having us. Bye-bye.
Bye. Is Michael here? Michael Foley?
Of course I am.
Of course you are, but I have to ask the question.
Yes.
All right, Michael, you've got some extra time here. You're going to start with talking about the topic that we asked you to, and then other questions will be welcome.
Of course.
Mike
Yeah,
Foley.
Anne gave me a heavy job today, and that was demystifying prescription drug coverage for those under 65. I don't think it's possible to completely demystify any aspect of healthcare, but I will do my best to talk about prescription drug coverage for those of you who are retired and under age 65. It's actually fairly simple. Until you turn 65, retired or otherwise, you are covered by the Welfare Fund's CVS Caremark plan. The Caremark plan, the formulary for the plan is always on our website. It's available to everyone to check to see if a doctor prescribes you a certain medication. A great place to start is the formulary to see if it's covered. And if it's not, you can always discuss the situation with us at the Welfare Fund about other options you may have. Your dependents are otherwise also covered under the CVS Caremark plan. You should have your CVS Caremark card with you. If you regularly go to the same pharmacy, they'll have your details available to you. And it should be relatively simple. As you know, when you turn age 65 and become Medicare eligible as a retiree, you're then moved into the SilverScript, the fund's CVS SilverScript plan. SilverScript is a Part D Medicare based plan. The formulary is a little different. There's certain things on the formulary that aren't included in the Caremark formulary, but it's all there on the website. It's a good habit to get into is to familiarize yourself with the formulary. The formulary changes at least twice a year. We update it on the website frequently, or when the new formulary comes out. And again, if you run into any issues regarding your prescription drug coverage as an under 65 retiree, for you and your dependents, we're always available to answer questions. For those of you who are under 65 and retired, you're also subjected to the situation that is happening now with the NICE PPO plan. That's the city's new medical benefit. The city of New York has always covered certain medications, and now NICE PPO has assumed that task. And those medications generally involve things like injectable medications, diabetic medications, ACA mandated drugs like low dose statins, things like that. So there's a relatively small selection of drugs that are covered by the NICE PPO plan for those of you who are under 65 and retired. And you should have a NICE PPO card. This has caused some confusion with a lot of our members. The city and NICE PPO did a so-so job of communicating the changeover to folks, and it wasn't completely clear. A lot of people assumed that the entire prescription drug model was changing, and it really wasn't. It was just that the drugs that the city has always covered were just going to now be managed by different entities. Those entities include Prime Therapeutics and Amazon Pharmacy. Some folks assumed that meant that the welfare fund's prescription drug plan was being altered or going away completely, and that's just not the case. So in essence, under 65 drug coverage is relatively simple. Age 65 is the key date to keep in mind for those of you who are retired and under 65. As you get close to 65, there's certain steps that you need to take. And once you take those steps, the enrollment in SilverScripts becomes relatively easy. It kind of happens somewhat automatically. So there's not too much to worry about there. But as you approach 65, 3 months out, you should be signing up for Medicare Part B, and uh, and then getting ready for entry into the Medicare world. Um, I'm happy to take questions. I think on this topic, one thing I've learned is that what I just talked about does not apply to 100% of the people in the room. Everyone does have their own experience. Everyone does have their own issue that may deviate from what I just discussed. And I'm happy to take any questions from some folks that might be having some issues if you're under 65 and enrolled in CVS Caremark. Gloria, how are you? We've talked before.
Actually have this.
Talk about sound. Oh,
What's going on?
what was that?
Oh, I have the silver slip.
Gloria,
Gloria?
it sounds like you have feedback from something, so I don't know if you can try to adjust. I don't know if you were using headphones or anything, but we'll come back to you.
Anybody else? If not, questions about under 65, other welfare fund related questions?
I'm also very interested to hear about anyone's experiences, good or bad, regarding prescription drug coverage under 65, over 65, whatever you'd care to discuss. Glenn, how are you?
Glenn Miller?
Hi, I'm good. Who in particular could I reach out to if I've had an issue with getting an injectable drug approved?
Of course. You can talk directly to Jennifer Melfi, who's my colleague who handles prescription drug coverage.
Thank you so much.
Of course.
Okay, Francis.
Yes, I have a little situation. I was due for surgery next week, and a couple of days ago, I wasn't feeling well, so I went to City MD, and they did a test on me and found that I had COVID. So therefore, the hospital canceled my surgery and scheduled it for 2 weeks away. But they require a PCR test before I have the surgery. And I'm wondering, I went to the local CVS pharmacy asking if they could do the PCR test, and they said no.
Mm.
And the on the counter, any test was the rapid test, not the PCR test. So I'm wondering where I have to go to get this PCR test so I can have the surgery.
Was your doctor any help?
I haven't called my doctor because the surgery is a surgeon who is out of the country right now.
Yeah. I would call up your regular, physician,
Primary care doctor.
yeah,
Yeah.
primary care doctor, and ask for their advice on the PCR test. They themselves might do one.
Uh-huh.
But yeah, most of the over-the-counter tests are all the rapid tests.
Yeah.
Um, and the surgeon who's out of the country, his office may have some advice as well on how to handle this, because it's in their interest to get you in there and under
Uh-huh.
the knife, so to speak. So
Yes. Okay. And now I have a stupid question. We've been discussing the New York Health plan.
mhm,
We have the welfare plan, which covers drugs,
that's right.
glasses, and all that. Will that be eliminated if we
No,
sign up for this
not at
New
all.
York Health plan?
No, not at all. No, well, we're not going anywhere.
Okay.
I'm going to be right here for the foreseeable future, as will all of my colleagues.
Yes, because I
Um,
love that plan.
Yes. So yes, that has been a common source of confusion for both active employees and for retirees under 65. The way they made this transition, it just wasn't clear. You had to really kind of scroll down on the FAQs on the NICE PPO plan to
Uh-huh.
see that the drug coverage they were talking about was all the drugs that the city had covered all along, pica, things like that. So injectables, PrEP drugs, chemo drugs, things like that. So nothing has changed with regards to the welfare fund. We still provide active and retired employees with prescription drug, dental, hearing, and vision. So that is not changing in any way, shape, or form.
Thank you, Mike.
Yeah.
Anybody else?
Mike, Gloria asked her question in the chat.
Yeah.
She said, how long will it take to process the Silver Script application?
It happens very quickly. Once we get it and we confirm everything, the enrollment happens very quick.
Thank you. Anything else? Any other questions? Boy, we're going to finish early today. Okay. Joan Grisano.
Hi, Joan.
Prescription drugs. But is there some issue?
We lost
Joan, you went back on mute for a second there. Yep.
I was wondering if there's any situation that affected retirees regarding Mount Sinai. I see messages on their website about Anthem, but I think that's only for people that aren't on Medicare. I'm a little bit confused. Do you know anything about that?
Indirectly, Mount Sinai and the issue with Anthem is generally impacts active employees. There's a lot of providers out there that get in these disputes. They tend to send kind of, not threatening notes back and forth, but very ominous sounding letters go back and forth. And it's all part of a negotiation process. And generally both sides hopefully will meet in the middle if there's a dispute like that. But what Jen was referencing earlier, with Presbyterian and things like that, while these disputes do come up, it's always wise to keep an eye out on things like that will change with regards to these new medical benefit plans, where things are altered after they're implemented, and certain providers, back out due to whatever reason.
But it doesn't affect, because I know I have an Anthem card, but because I have Medicare as my primary, it shouldn't affect me. Is that what you're saying?
No.
Okay, thank you.
Erwin.
Hi, Erwin.
Hi, I'm Michael. I wanted to follow up on this question about hospitals, specifically Presbyterian. This is a major New York hospital. I wasn't sure when Jen referred to it, whether she was talking about the active plan, or whether she was talking about the retiree plan.
More than likely active. As City of New York retirees, all of you have very good medical benefits. A combination of Medicare and GHI senior care as your supplemental medical insurance. Generally that's kind of bomb-proof to a certain extent. You're not subjected to some of these whims that occur with active employees and providers like Presbyterian potentially withdrawing. In my experience, I've seen a lot of these hospitals and hospital groups make certain threats, but it is really what they like to do is sort of use that as a negotiating tool. And that's not to discount anything that could happen, but everyone wants a little bit more, and they're willing to scare people to get it. So be cautious, be proactive. But generally, those kinds of changes impact active employees less so than retirees.
Okay, thank you.
Elizabeth?
Hi, Elizabeth.
We can't hear you, Elizabeth.
Can you hear me now?
Yes.
As they say on the movies. I called Mike a couple of weeks ago to ask about the fact that I had received a new Medicare health insurance card, which we all know we've had for a very long time, and so you're all familiar. He suggested I call Medicare. Medicare said that this is possibly part of a large breach in information of, and of course that means you don't know who else is involved, has been breached. But I just think that it's important for us to know that this has happened. They did send a new Medicare card, which will take effect on April 14th. And so I think people have to kind of pay attention and be aware that this has happened even in an area where we think of as such a secure area. So that's what I want to bring to the
Elizabeth,
group.
thank you for mentioning that. Scams and things like that are very, very real and very, very dangerous. I think all of you as retirees under 65, over 65, you're in a good position where you can generally ignore things like certain letters, phone calls, emails, things like that, that don't feel right to you. You should not respond to generally anything like that without either calling us here at the Welfare Fund, talking to colleagues, talking to the retiree chapter leadership. You're in a position where you've got an established medical benefit plan and you've got an established supplementary benefit plan from the welfare fund. There's very little that can occur that would prompt someone to email you, text you, call you, and you should be almost paranoid about sort of situations like that. Always question it and always be skeptical of it and never agree to anything before you do some due diligence. So thank you.
Thank you.
Thank you. Albert Sherman?
Hello, Albert.
Albert? Well, let's go to Bonnie and we'll come back. Bonnie?
Yeah, I just want to emphasize that if you are over 65 and on Medicare, do not worry every time you see that some hospital is threatening not to renew its insurance, its contract with an insurance company. Your contract with the hospitals is through Medicare. That's all you have to worry about. Medicare sets the rates, Medicare pays the hospitals. Once Medicare is finished paying your supplementary insurance, which in most cases here is senior care, they pay the other 20% minus your copay or whatever. So you don't have to worry about the contract. The hospital's contract for you is with Medicare. So don't panic every time you see that. It's
very true.
Scary
very
as
true.
hell, and every time I forget.
You all worked very hard to get where you are right now, and that's in a good place generally. So,
right. Okay, thank you, Bonnie. Albert? You have to unmute, Albert.
You got it? Hello?
Yes.
Okay, good. Hi, Mike. How are you?
Good.
I have a question. So I'm new to the world of Medicare, and it's great. It's doing great. I have two questions though that confuse me. So when I go to a doctor, they're asking, once I meet my deductible, they're asking for copays of the $15, which was required. But then I was told by GHI that you should ask the doctor if they can bill Medicare first, and then they will bill you for whatever is remaining. A lot of times what's happening is they're asking for less than the $15, and sometimes they give you give them the $15, but you'll never see the refund back to yourself. So somebody's keeping the extra money somewhere. Now I know my requirement is to pay the $15, but why is that happening?
It's a good question, Albert. I don't have any direct knowledge of why that would happen. Bonnie, you have any insight on that?
Yeah, a lot of places they want to get their copays up front, but with Medicare, the 20% in some cases is less than $15. So you should say, if you can, you should tell the doctor or the hospital, whatever, send me a bill and make sure you send the bill to Medicare first. Then it goes through the process, goes to Medicare, then it goes to senior care, and then and then the hospital, then the doctor will bill you
Right.
$15 or less if it's less.
Right, some doctors don't even want to entertain that. They said, we need the copay up front and that's it. And,
Well, I mean, most of the time, it's not less than $15.
right.
So.
I'm not saying it happens all the time. And the other question I have for you is, if I live in the state of Florida, and for some cases, sometimes I know there's a CVS somewhere every corner of Florida, but sometimes I'm in an area that maybe CVS does not have that particular medicine that I need, but a Walgreens has it. Now, if I went to Walgreens, what would happen to the payment for that prescription?
Well, the funds SilverScript plan, Albert, are you in SilverScript?
Yes.
Yes. The funds SilverScript plan is a nationwide plan. It's a Part D based plan, so therefore it's a Medicare Part D based plan, so it's national. So it really shouldn't matter what pharmacy you go to. Um, you may see some deviations depending on what medication you're being prescribed.
Okay.
But it really shouldn't matter what pharmacy you go to.
So in other words, if a CVS didn't have a certain medication that I needed, but Walgreens had it, and say there was no copay for it, it would be the same? It would be the same? Walgreens
Well, I would
honor
check the formulary to make sure it's covered under the SilverScript formulary first.
it is.
It
But
is.
but like CVS didn't have it. That's all I'm just saying. And I had to get
Like
it.
it was out of stock on it?
Right. Yeah.
Yeah.
And
No, it really shouldn't matter what pharmacy you go to.
Okay. Thank you, Mike.
You bet.
Mary Suri. Can't hear you.
Oh, can you hear me now?
Hi, Mary.
Okay.
How are you?
Yeah, I have a question about this $15 copay too. I go to at least 5 or 6 different doctors, all at Mount Sinai, and pay. Plus, several times I've had physical therapy, so that I've paid $15 every single time for all of those. Is there some I can't really keep a separate receipt for each one, and I don't want to negotiate with like all these different doctors. Is there any way of getting any of that money back?
Not to my knowledge. I'm not aware of copays being subject to any reimbursement type program, similar to like your Medicare Part B reimbursement or something like that, or your IRMA reimbursement. I'm not aware of that. And I think that's why the PSC fought so hard in that case about the copays and whatnot. And ultimately the city did win. When that ruling went in, that's, as Bonnie alluded to, people want that, they want that copay up front. And I don't think it matters that everyone's under the same roof. They consider themselves to be different.
Okay, Eileen.
Hi.
Hello, Eileen. How are you?
Hi. Okay. I have a question about the maximum payment on the prescriptions.
Yes.
So I know it went up to 2,100
Yes.
for this year.
Yes, I believe that's the case.
Right. But I also understand that we don't actually pay the whole 2,100 because
That's correct.
PSC
Yep.
picks up part of it. Where can I see how much is left? Because what I get from what I get from Silver Scripts and what I get, it's all different, it's all different information.
Yeah. So Eileen, I would ask you to contact my colleague Jennifer Melfi. She has access to the specific database that you can talk in private with her about your specific situation, and she can give you much more insight into exactly where, for instance, where you sit at meeting that threshold. Most folks meet that threshold around this time of year. But you're correct, the fund does eat some of that cost. So you could either be very close to it or have already met it. But if you have a discussion with Jennifer, and I'll put her contacts into the chat before I leave, she can answer that specific question for you.
Okay. And when I go to the pharmacy, is it safe to assume that they're charging me the correct amount?
I hope so. I would say this.
Especially when I'm close to meeting that threshold.
Yeah. When you're close to meeting that threshold and something feels off to you, advocate for yourself and question the pharmacist. And call us, even if it's from the counter, just call us and we can quickly check. Um, you know, the one responsibility that I like to emphasize everyone still has, no matter where they are, active, retired, or whatnot, is to maintain a healthy level of skepticism when you're dealing with pharmacists, doctors, anybody, myself included. Um, just if something feels off to you, question it and make that phone call to us here at the Welfare Fund. We'll always pick up the phone, and we'll try and to immediately solve that question for you.
Okay, terrific. Thank you.
But generally, in my experience, and I think Jennifer will tell you this the same, tell you the same. Generally, things move along fairly easily for the most part. It's rare that there's a particularly bad situation where someone doesn't have the correct record or file. It's funny for a gigantic government agency, Medicare and its Part D drug plans actually function pretty cleanly.
Okay. Yeah, and I mean, considering what I get is a once a month, it's a once a month refill. So I would assume by the next time everything should catch up.
Yeah.
Okay. All right. Thank you.
You're welcome.
Okay. Augustine Maldonado.
Hi, this is actually his wife, Elaine.
Hi, Elaine.
This is a slightly off the drug topic, but I really wanted to thank Michael for something. I had attended one of the meetings where you were talking about those old Wohler's policies, Amber, Mercer, the catastrophic. And I heard what you said, and I decided to test it out when my poor Tim was in the hospital with sepsis, all right, and had a bill. And it was daunting. I was muttering under my breath, but I submitted that Wohler's policy, and I got back every out-of-pocket penny after Medicare and then the Medigap paid. And I found where every time Tim paid for something, I put it all together. And I thought, I can't believe was like close to 50 years and we never made a claim. And I really want to thank you for that. And I hope you do that again so more people find out.
Yeah, thank you, Elaine. And it was great to talk to you and hear about your experience, because I really can't emphasize it enough. If you do have the catastrophic policy, use it. Just bundle those whatever out-of-pocket costs you have and send it in. And generally it works out. And Elaine's living proof.
Really, my husband is, right?
Or your husband is, yes.
But the key that you said, which was really unbelievable, that the way that the policy is written, it talks about you have to lay out, it has to be like $10,000. It seems like it's out of pocket. But when I heard you say no, it's the submitted charges, which is night and day, because we're so used to meeting a deductible, not a deductible of charges, but a deductible of out of pocket. And I went for it, and they actually processed it fairly quickly.
Yep.
So anyway, many thank you.
Happy to help, Elaine. Good luck, and good luck to your husband.
Okay, thanks. Yeah, he's doing fine.
Good.
Mike, maybe you can put something on our webpage that would give a...
Happy to. Yeah, happy to.
Okay. Linda Iannuzzo.
Okay. I'm sorry. Could you just run by that? Because I do have the catastrophic, and I know you talked about it before.
Sure.
And I had pulled out some of my numbers, and fortunately or unfortunately, based on my calculations, I wasn't even close to being able to submit. So I guess that's kind of a good thing. But
generally, like Elaine, like Elaine alluded to, is if you have like regular doctor visits or some procedures, as you know, the upfront costs for all these procedures are usually very happy. When you get the bill and it's like it says, here's the initial charge of $5,000, and here's what your insurance paid. It's that initial charge that counts towards the deductible. So it's if you're healthy, the one drawback to being healthy is it's a little harder to meet that deductible. But be patient, and when you do, just Linda, go to town on this policy, because when you meet that deductible, just tally up all of your out-of-pocket costs aside from copays, and just submit them. And I'm talking even some dental costs. One thing, and this is between you and I, one thing I've found is that the wording on dental reimbursements through catastrophic is it has to be sort of like accidents or emergencies and stuff like that. But if your crown malfunctions or something, I'm pretty sure you can probably submit it as an accident, so to speak, or an incident of some kind. This is a very open-ended policy. Linda, just give me a call if once you feel you're close to that deductible, we can talk a little bit more about it. But as I've always said, I just think it's a misnamed policy. It's not. It shouldn't be catastrophic. It should be an everyday policy. So.
Okay, I'm sorry, just clarify for me one more time.
Yeah.
So if I go to a doctor or I
Right.
have a procedure done and the Medicare statement says the initial cost was 5,000, but Medicare only approved 3 cents,
Right.
whatever it is. So
Yeah.
it's the 5,000 I'm looking at.
That's correct.
Okay, perfect. Thank you so much.
You're welcome.
Cheryl?
Cheryl, get to unmute.
Yeah, I actually don't think it's the initial charge. It's what Medicare approves. Because the doctors always charge 5,000 and Medicare approves, I don't know, 700, because I'm meeting my 10,000 this year again. And I'm
Okay.
in the process and I have it written. I'm pretty sure it's what Medicare approves. It's rare that the doctor would charge 5,000 and Medicare would approve 3 cents, but what's common is 600 and Medicare approves 200 and Emerald approves whatever. So you
I will.
hospitalization and you will meet your deductible. One.
Right.
Right. There's hundreds of but I'm almost certain you should call again Amber or Corebridge. They're very good about telling you.
Yes.
But I have written down and that I've been submitting, and it's what they cover. And Medicare covers a lot of stuff if you unfortunately have a lot of stuff wrong with you.
Cheryl, I'll certainly defer to a lived experience like yourself. So I'll double check on that.
But it's usually close, it depends. Getting to 10,000 isn't as hard as you think, but if you're healthy generally and don't see doctors much, you might not get there. It's
Correct.
worth just calling them. They're very
Yep.
helpful if you call them.
Thank you.
That's all.
Thank you.
Question. Will you wait till you have the 10,000 and then submit? Is it from a calendar year and then submit?
Cheryl, unmute.
I would just keep submitting, especially if you know you're going to have certain treatments and they cover, let's say you have an expensive medication and SilverScript covers it, but it's $175. You can send that $175 bill to them and they'll just keep adding it up.
Oh, okay.
I have someone who doesn't want the copay and I'm paying, Medicare pays $102 and GHI pays whatever. I just send the Medicare is it called ESN? Whatever the thing is you print out from Medicare or they mail to you. It's whatever Medicare covers. And if you have regular health visits or regular therapy or regular physical therapy, and you have that particular catastrophic plan, it adds up to $10,000. Well, depends on how many health issues you have, but it's whatever is covered. Call them. They're very helpful. If I could find their number, you have their number probably, Corebridge.
I do. Yeah.
Or
You can always just call me as well, and
Yeah.
I'll steer you in the right direction.
So just one last question on this. So is there a time limit on when to submit? So in other words, if I go back to my 2025 things, I can submit it still this year?
Mm-hmm.
Great. Thank you. Thank you. Thank you. Thank you.
Okay. Well, thank you, Michael, as always.
You thought you were going to get this meeting over early. No such luck. No such luck.
I'm just, I don't know if you were on when Len had the problem with the sound.
Yeah.
Oh, that was really unfortunate. Anyway, thank you, Michael, as
My
always.
pleasure, everyone. Great talking with everyone. Don't
Okay.
hesitate to give me a call.
Okay.
Thanks, Michael.
Couple of announcements. The next meeting is on May 4th, and the topic is the National Domestic Workers Alliance. We're going to have a couple of speakers, thanks to Marcia, who's put that together. The luncheon in the summer is going to be on June the 15th. We have a committee working hard to improve whatever the problems were last summer, but you can hold the date, June the 15th. So, good meeting. Thank you all for coming. Okay. Thank you, everybody. Have a good
Thank you.
day.
Great meeting.